Well, I think everybody is out of the waiting room and into the session. So I'm Deborah Schur, and I've had the privilege of being the director for the Fellows Track Symposium for a number of years now. And I want to welcome everybody to the virtual version of this to help us get through this difficult time. So our first speaker today is Dr. Safwan Badr, who is a distinguished and internationally known researcher and clinician in sleep medicine. And he is at Wayne State University, and we are delighted to have him speak today about central sleep apnea. And we will follow this session by another session with Dr. Toolmater, who I'll introduce at that time. I need to see if I can shift these slides, which is not working. Let's see. Here we go. And I want to remind everybody that there are sessions coming up. The next virtual session is this Thursday at 3 p.m. Dr. Katra from Northwestern University, followed on July 14th by the workshop on COPD by Dr. Celli, and the critical care ultrasonography workshop by Dr. Pierre Corey on July 14th. And very importantly, we'd like to use the code here to assist in evaluating the effectiveness of the of this webinar series and making recommendations. So please do complete the survey. So without any more delay, I'd like to turn this over to Dr. Badr.
All right, well, this is an adjustment for all of us to move from the traditional way of giving presentations to actually, I have to do this, to the virtual world, and it seems like the transition has its hiccup. Well, I love to talk about central apnea. It's one of the things that I have a lot of passion for. And if people will remember, one thing is that I consider central apnea as the foundation of all sleep disorder breathing. And that's part of what you will hear me talk about. So is it a headline or footnotes? So we'll talk about etiology, risk factors, relationship between central and obstructive apnea, and outline a management approach. So we'll start with an example of a patient who has the classic presentations and classic features of sleep disorder breathing. And what we have here is, and it's obviously very hard for this to be interactive, it has an arrow that is pointing to a central apnea. And when we talk about the different etiologies of this, the question is what's actually causing this? What is the underlying mechanism that is showing this? And the main theme here is that the driver of most central apnea is hypocapnia. The big driver of breathing in humans is CO2 production. So if we lower CO2, would cause hypocapnia, we can induce central apnea. This does not happen during wakefulness because we have something called the wakefulness drive to breathe, which is powerful and overcomes this inhibition. Sleep masks this inhibition. And I always like to show the very, very original study by the late Jim Scatterwood and Jerry Dempsey from 1983, where they induced a period of hyperventilation, and that hyperventilation is using nasal mechanical ventilation. And actually, this is pre-nasal mechanical ventilations that we know. This was even an ambu bag. This is the end-tidal CO2 on top. And you see they lowered the CO2. If you lower the CO2 adequately, you will induce central apnea. We can induce central apnea in every living adult human, man, woman. Not sure about child. It may be a little bit different. The difference between these two is what we now call the CO2 reserve. That term was not around in the 80s. And this is the term we use, which is if I have to lower the CO2 by -3 torr in one person, that is their CO2 reserve. Another person may be -5. That is their CO2 reserve. And there are differences between people, between populations, and also a gender difference in the CO2 reserve. Now, sleep causes a whole lot of other changes that affect respiration. It reduces activity of the upper airway muscle, and it affects load compensation. It also causes some degree of hypoventilation, and that is relevant. We all develop some degree of hypoventilation during sleep, and that may play a role in the propensity to develop sleep apnea. So classification, and I don't particularly like classifications because I don't feel that they tell a story. However, this is what we have with the ICSD-3, classifying central apnea into one with Cheyne-Stokes, medical disorder, central sleep apnea due to high altitude, medications or substance, primary central apnea, and treatment-emergent central apnea. Just looking at this, there is one big problem with this classification. It doesn't really tell us anything mechanistic. For example, Cheyne-Stokes respiration may have a different medication mechanism than central apnea that's due to medication or substance. Primary central sleep apnea, we figure out no etiology. That's why we call it primary. I suspect it's a lot less than we think. And finally, treatment emergent, which has become a topic of interest in the past 10 years after initiating CPAP. A better way of looking at it is hypoventilation or post-hyperventilation. And any condition that causes hypoventilation will increase the likelihood of developing central apnea. However, some of these may not necessarily meet the criteria. A patient with neuromuscular disease, as they fall asleep, they may develop what looks like a central apnea, but it's in effect, it may not be a complete apnea, maybe a significant reduction in ventilation, and it may not necessarily be coming from the central chemoreceptors, but it may simply coming from decreased tidal volume. However, hypoventilation may also increase the risk for developing post-hyperventilation apnea. And I want people to hold on to this thought. Remember this idea that if your baseline CO2 is higher, you're at higher risk of hyperventilation-related central apnea. And this is probably the most common type. This is what we deal with in our practice, in our clinical settings. So this particular individual has a normal, relatively low, but within normal range PaO2 of 82 millimeter of mercury and a PCO2 of 34 millimeter of mercury. So this gets us into the issue of the possibility of what is it that causes central apnea. And what this will be a little hard to describe in a virtual setting, but I'll do my best here, which is if we think of central apnea, we shouldn't think of it as a single event. Now that it is summer and many of us have ACs running in our homes and our places of work, we have to think of when does the AC turns off. Think of the moment when the AC turns off as your central apnea. And then the temperature in the room rises and the AC resumes. That is a form of periodicity that has a loop. And that is the driver of central apnea. The driver is not a single instance. If I had developed one central apnea, that's no big deal. But the fact is that when I have one central apnea, it triggers a process of ongoing instability. And we call this apnea begets apnea. And when an apnea begets apnea, that's what we actually develop. That is actually what happened to us with the periodic breathing. It's an apnea that begets apnea. So what are the mechanisms? Impaired arousal response, low loop gain, hypercapnia, or high controller gain. Well, each one of these has its own set of issues, and we need to think about them differently. So, which one would it be? High controller gain. So, if we have a high controller gain, this is actually will cause a significant sleep apnea. It's a recurrent sleep apnea, one of them after another. So this is what it looks like. It looks like you have one event and then an arousal, changes in oxygenation, and one event begets another. It is the recurrence of central apnea that causes the problem. And the way to look at it is as a loop. So the idea of a loop, and that's an engineering concept, was introduced in this field about 10, 20 years ago. Hyperventilation causes hypocapnia, which causes central apnea, changes in chemoreceptors, changes in sleep state, and a recurrence of the event. And it goes up and down like this in a circular fashion. Apnea begets apnea. That is the key theme. One event triggers another, and it becomes breathing instability. So this construct is, we think of a generator, which is a controller, and that controller the next one will changes the chemical stimuli at the airway and the lungs, and then through changes in ventilation, and the changes in the plant will changes CO2, and then will produce another change. So it's a cycle. So these are two terms that are important. The brain and the generator is the controller. It's what controls the breathing. And the controller affects the plant. The plant is the lung, chest wall, airways. Now, I would like to get another term here. Think of the plant as a room when we talk about heating and cooling. Think of it as a room. That is the plant. And that you'll see why this is relevant. So the first one is how effective is the system in reducing the CO2? If I'm hyperventilating somebody by 2 liters per minute, I may lower the CO2 by 1 millimeter of mercury, or may lower it by 4 millimeter of mercury. And that is the plant gain. So a plant gain is how effective you are. Again, I want to take you back to the analogy of a room. A small room, for the same AC, you lower the temperature more than you will lower it in a big room. So the volume of the lung is an important part in the plant. On the other hand, when do you turn off the system? And that is the controller gain. Now, the term controller gain sounds very fancy, but those of us who are in the pulmonary field, and people like me who've been in pulmonary since the Jurassic era, we have another term for it. We call it chemoreflex sensitivity. So your sensitivity to CO2 or your sensitivity to O2, that is your controller gain. And this is here for the purposes of central apnea is the response to hypocapnia. So let's start looking at how does the chemoreceptor sensitivity affect it. So this is the relationship between PCO2 and ventilation. And this is the curve. This is a chemoreceptor reflex sensitivity. And you see when CO2 drops to 38 in this particular individual, this person goes apneic. And this is the CO2 reserve that goes with it. Now, if we decrease the chemoreflex sensitivity, you have to go down to 36 to induce a central apnea. And that person have a higher CO2, a wider CO2 reserve. Now, if you take the person in red, it's a very steep chemoreflex sensitivity, and all they need is a very small reduction in CO2. So the curve in the middle, for example, could be your average healthy male. The light blue one to the right, that could be a healthy premenopausal female. And the steep red one, that could be somebody with heart failure. So where you start, depending on your chemoreflex sensitivity, your tendency to develop central apnea may be different. Now, this is where this gets complicated. Remember what I mentioned about hypoventilation. If you have hypoventilation, meaning your baseline CO2 is high, are you more or less likely to develop central apnea? Now, old textbooks still say that if you have low CO2 to begin with, you are closer to your apneic threshold. And we're going to examine that statement and see if that's correct. So this is a person who starts at this somewhere around 40 in the baseline. Chemoreflex sensitivity, we are going to keep it constant. Now, we're going to take the same person baseline For whatever reason, we treat them with a medication, give them acetazolamide, do something, and now their baseline CO2 is lower to begin with. This is their baseline. And look what's going to happen. Look at the difference in the CO2 reserve. Which one is bigger? The one with the lower CO2. And the question is why? So what we're saying here is that the plant gain in somebody who has a higher CO2 is larger. So it is much easier to lower the CO2. Let's think in terms of temperature. If you have a room for a given sensitivity of your thermostat and a given anything in the room itself, if you're starting with a higher temperature, it's easier to lower it than if you're starting with a lower temperature. It's almost physics. So having low baseline CO2 is protective. It is not, it is salutary and not adverse. In contrast, if you're starting with hypoventilation, you are more likely to lower your CO2 for a hyperventilation and develop central apnea. That is the example we see with many patients with neuromuscular disease or patients who are on opioid. Slight increase in their CO2 make them more susceptible to developing hypocapnia for a given hyperventilation. So this is the question now. I wanted to flip the question to make it at the end. So what is the effect of decreasing steady state PCO2 on susceptibility to central apnea? One could say no effect because chemosensitivity is not changed, and that's incorrect. Increased because the PCO2 is closer to the hypocapnic apneic threshold. That is also incorrect because the apneic threshold is a result. The last one, increased because of decreased CO2 stores, is also incorrect. And the correct answer is decreased because of decreased plant gain. Another element of plant gain, obesity. Large body, small lungs. Obese individuals have smaller lungs, which meaning they have a higher, larger plant gain. So all of these things go together. The plant gain and the controller gain, both of them will affect your propensity to develop central apnea. So risk factors, we talk about age, gender, menopause, medical conditions, heart failure, CHF, CVA, opiates, hypothyroidism and acromegaly. We don't always see them. Sometimes we see them in the sleep clinic, but sometimes our endocrine colleagues don't think of them as often as we'd like. And then there's at the end, there's this entity called idiopathic or primary central apnea. Okay, which sleep state is the least prone to central apnea? Is it N1, N2, N3, or REM? And the answer to this is REM. This is one of the fascinating and most confusing things about REM is that it's a very active brain. Even though the periphery is paralyzed, however, the ventilatory control is closer to wakefulness. When you have a lot of vague events on polysomnography, one way to make me lean to think that they are central, we're talking here about like hypopneas that are hard to determine whether they are obstructive or central sometimes. If they disappear in REM, I'm more likely to consider these to be central. So, and this is an important consideration. REM, for the most part, is impervious to hypocapnia. Clinical conditions, CHF, opioid analgesics, and obstructive sleep apnea. The most common comorbid condition for central apnea is obstructive apnea. Most of the central apnea we see is in patients who have also concomitant obstructive apnea. And finally, there is the treatment-emergent, which we'll talk about for a little bit. This is a study by Javahiri about central apnea in heart failure. And this is from 1998, but the results are still very relevant. Patients with heart failure with reduced ejection fraction, that term wasn't used in 1998, I don't believe so, clearly have a high likelihood of central apnea. One problem with this study is that this was a VA-based study, so the majority of the patients, if not all, were males. So these are that's the difference between that and a lot of other newer studies, but the idea still holds. This is another example of a patient who had obstructive sleep apnea in the baseline, and then we applied CPAP. And look what happened. What happened? Central apnea has emerged. And this entity is what we refer to as treatment-emergent central sleep apnea. The interesting thing is we've been talking about it only in the past 10 to 15 years. However, those who like the history of medicine, which I like, and try to find some old literature, you will find that it actually exists in old original articles by Weitzman in the late 70s and by Onyal and Lopata in the early 80s with tracheostomized patients. So the phenomenon has been known, and it's been thought to be a transient phenomenon. It didn't have a label for a long time. So which one of the following statements regarding TECSA, treatment-emergent central apnea, is correct? Does it develop in the majority of patients undergoing split night? Does it indicate the need that we have to initiate BPAP therapy? Does it happen only in patients with central apnea in the baseline? Or was it that the majority will experience complete resolution? And the correct answer is that the majority will experience complete resolution. Now, the issue with this is that the problem with a lot of studies on this condition is that it includes patients who did not have any central apneas in the baseline, as well as patients who had central apnea. So, and that's why you will see that the literature is kind of messy. The other problem is that most clinical laboratories and most studies that are based on clinical series have difficulty distinguishing central from obstructive hypopneas. And that actually is an important limitation because without knowing whether somebody has central events, it's hard to know whether it's truly treatment emergent. This is a study looking at the natural history. And what you will see in the beginning here, there is a wide range. And the vast majority of the patients, it actually either disappears or attenuated. And this is probably reflects the experience of the vast majority of clinicians who treat this condition. So treatment recommendations. We'll take the same patient and we'll go a treatment recommendation. Well, you can have BPAP, you can have CPAP, you can have ASV, you can have oral acetazolamide. And which one is going to be? Which one is considered a standard treatment? So I'm going to pause here to make a broader statement about the treatment of central apnea. The vast majority of our work is on central apnea, is in patients with central apnea and heart failure. And a lot of the outcome data are derived from studies on that included obstructive sleep apnea as well. So the literature and the treatment approaches are really not clear and not definitive. So CPAP is the treatment of choice. So there is no specific treatment for central apnea. All the modalities that we use for central apnea are for the most part the ones we use for obstructive sleep apnea. Most modalities, they work by dampening post-apneic overshoot. So we're not preventing the original apnea from happening. And remember, if you have a single central apnea, it is no big deal. The problem is that a central apnea triggers another apnea and another apnea and another apnea. So most modalities will dampen the post-apneic overshoot. For example, if you apply positive pressure, you keep the airway open, you prevent obstructive apneas and the ventilatory overshoot that's after it. You increase lung volume, and by increasing lung volume, you dampen plant gain. You may raise the oxygen level, you may raise the PO2 slightly by increasing lung volume. And in that case, you may decrease the chemoreceptor sensitivity as well. So most of these, you prevent arousals. So most of them dampen the post-apneic overshoot. We have a variety of positive pressure devices. We have CPAP, we have BPAP, and we have ASV, which is adaptive servo-ventilation, a fancier mechanism of BPAP. You can also alter the chemical stimuli. Supplemental O2 has been tried, and there's a good physiologic reason to think that it'll actually work. Because it's caused by hypocapnia, if you can actually give a small amount of CO2, you may actually succeed. And I've actually tried it in a tracheostomized patient. There are approaches to deliver it. You can do it with some individuals will use a dead space, increasing dead space. The use of hypnotics to blunt the next arousal, I'm very cautious with this one. I'll tell you when we get to it, but it's been tried. Now, acetazolamide, it makes a lot of physiologic sense. It's another pharmacological approach. And then finally, phrenic nerve stimulation. However, having said that, none of these modalities that I'm discussing have had significant studies that looked at long-term outcome. Most of them look at intermediate outcome. So why does CPAP improve central apnea? Well, first of all, the vast majority of central apnea patients will have concomitant obstructive sleep apnea. And you'll have a whole lot of events in between, and these two may trigger each other. Second, the overshoot after an obstructive apnea could cause more hypocapnia and hence a decrease in another central apnea. The other issue is many times the airway is actually closed during a central apnea, and by opening it, you dampen the overshoot. And you also increase O2 stores. It has been used, and there has been improvement in intermediate outcome, which is intermediate outcome is AHI or central apnea index. However, if we think of central apnea, we have to think that a central apnea, underneath it, there is central hypopnea that's often missed. There's upper airway obstruction intermixed with it, and there's breathing instability. And you really have to look at all of this in a holistic fashion. So this is work that's done by our group. This is 25 years ago, and looking that the upper airway is actually closed during a central apnea. So this is the PES is the esophageal pressure and the flow on top. And you can see when the apnea begins, it is a central apnea because there is no negative deflection in the esophagus. This is what you see here is cardiac pulsation. So from image 2 to image 5, these are all central apnea. This is one central apnea. And at the end, you can see a resumption of effort at 6. This is the images you see on the bottom. These are images of the retropalatal airway. This is also the old days. What we talk about cut and paste, these images are actually cut and paste from actual prints. And look at image number 4, and what you will see here that there is the airway is completely closed, and at 5 is closed. So in susceptible individuals, the airway during central apnea is actually closed. So that links these two conditions together. Now, I was one of the people who were very excited about CPAP for central apnea. But then I was crushed when the CANPAP study was published in 2005. And what it shows us that it actually didn't work. Well, this is the issue. They took patients with heart failure. 128 received, divided between CPAP and no CPAP. And so CPAP of 128 and no CPAP 130, follow them up for 24 months. Now, the top graph, panel A, tells us some of the story. So in the CPAP group, we were able to lower the AHI. However, the AHI was still somewhere around 20 because that was not based on titration. That was an empiric number. Everything else did improve. Yes, there was an improvement, but there was no normalization of respiration. And then when they looked at outcome data, heart transplant-free survival, there was absolutely no difference. So clearly it tells us that CPAP, at least in the way it's used, is not very effective. And that pretty much affected how we all think of nasal CPAP. Now, bi-level is a common one that is being used, and this is the problem. We see this in clinical labs all the time. They switch patients to BPAP immediately. And what you will see here is that BPAP, if anything, and this is the worst by 10, you can see that BPAP, for the most part, worsens the condition. BPAP without a backup rate is likely to worsen central apnea. We induce central apnea in the research laboratory using BPAP. And the reason is you're simply increasing tidal volume and causing, by decreasing tidal volume, you are causing some degree of hypocapnia. Adaptive servo-ventilation was a device that was invented to overcome the issues and limitations with BPAP. And the idea, it's actually smart BPAP that gives you what you need, not what you want. BPAP, you generate an effort, it gives you what you want. You generate some effort, and it gives you what you want. But ASV doesn't work that way. ASV, it gives you what ASV thinks you need. So it looks at the average of your previous 3-4 minutes, and it gives you 90% of that. So if you are in a period of decreasing ventilation, it will increase the amount of pressure support. If you're generating large breath, it decreases the amount of pressure support. So it gives you around 90% of your long-term average minute ventilation. And this is what it looks like here. And you can see, so as, for example, when there is clear evidence that of decreased effort, you can see here's the effort is high and the amount of pressure support decreases. The effort here is low and the amount of pressure support increases. So it tries to compensate. And in doing so, it prevents you from hyperventilating. It prevents you from overshooting. So in principle, it should really work. And when you look at it in terms of which one is most effective in terms of efficacy, not effectiveness, efficacy, which is the immediate effect, ASV works very well. And this is an example where you can see in a group, look at the central apnea. This is the control. Supplemental oxygen decreased it. CPAP decreased it. Even bi-level with a backup rate decreased it. ASV was the most efficacious. We're not saying most effective, most efficacious in decreasing the number of events. However, there are some caveats. So let's talk about them. Which of the following treatment is associated with increased mortality risk in patients with predominantly central apnea? CPAP in patients with heart failure and preserved ejection fraction, BPAP in opioid-associated central apnea, ASV in patients with heart failure and reduced ejection fraction, or CPAP in heart failure and reduced ejection fraction. And the answer is adaptive servoventilation in patients with heart failure and reduced ejection fraction. This is the study. And this study it changed a lot of our dynamics in what we do in this business. And you can see death from any cause and death from cardiovascular causes. Clearly, the ASV had higher mortality. This study was terminated early. This was a huge study, 1,325 patients in multiple countries. And it was supposed to actually answer this question and tell us whether it works or not. And it shows that in this population of heart failure, you actually increase mortality. And as a result, this became contraindicated. Now, this also highlights the idea that we absolutely need to do clinical trials. We cannot infer anything from intermediate outcome studies. Let's talk about arousals. And this is starting to gain some traction in the field without enough empiric evidence. And I'm very, very, very cautious about this. There is only a handful of studies, and this is one of them, 20 patients, and there was a decrease in central apnea from 26 to 7. Arousals decreased. There was some decrease in Epworth. However, OSA worsened in 3 patients. So I'm very concerned, and I'm very concerned about using it in patients with other comorbid conditions. We do not have enough evidence to make a statement about arousals. And I'm very cautious about all the other consequences. So you will not see me using it. Supplemental oxygen. Well, why would supplemental oxygen work? Well, there's multiple reasons. The simplest of them is by eliminating any degree of hypoxia, you saturate the carotid body. If you saturate the carotid body, you decrease the magnitude of overshoot. You decrease chemoreceptor sensitivity. So that's one of them. We all have about 20% of our drive theoretically is coming from our carotid body. Patients with sleep apnea may have more than this, may have 30 or 40% of their drive coming from their carotid body. Okay? And if we shut off the carotid body with supplemental oxygen or decrease its activity, because we're not giving a full hyperoxia, you may actually decrease the overshoot. Now, another thing that supplemental oxygen does is it actually slightly increases cerebral CO2. So this PCO2 in the brain increases because of the Haldane effect. It shifts the CO2 from the intracellular to the extracellular space. And these are the studies. There are multiple studies. Now, this has not been studied to the extent we like, and now there is an ongoing NIH-sponsored study across the country for heart failure and central apnea using supplemental oxygen. So we'll have to wait for the results. Personally, I believe that long-term, this may turn out to be a very effective treatment. The problem right now, you cannot prescribe it outside the VA system because if there is no hypoxia, you cannot prescribe supplemental oxygen. And one last thing, transvenous neurostimulation. Again, if it's the carotid, can we stimulate one phrenic and get it to work? Well, this is the pivotal study that was used to obtain the FDA clearance. And what you can see is that in the treatment, 29% markedly improved, 31% moderately improved, 19% mildly improved. So this is actually a significant improvement in more than 80% of the patients. So this is not a bad outcome. So overall, however, remember, this is still intermediate outcome. This is not long-term outcome. So our approach, and I would like to preface this by a statement I always say when I talk about treatment of central apnea. When data are few, experts are many, and I'm one of many because none of us have data, definitive data. In our own approach, we use similar principles for CSA at the diagnosis or PAP emergent CSA or treatment emergent CSA. Always treat the underlying condition. We focus on treating the underlying condition. We initiate CPAP, it's always the starting point. We have had a clinical series showing that about 50% of patients will respond to CPAP. We do not use ASV or BPAP for CSA with reduced ejection fraction, heart failure and reduced ejection fraction. While the contraindication is just for ASV, we extend it to BPAP out of concern that the mechanism of action may be similar. It's a high positive pressure. Patients who fail or are intolerant, we give them supplemental oxygen or emphasize more medical management of heart failure. Patients with preserved ejection fraction or primary CSA, we try CPAP. If it fails, we try ASV. And we try BPAP with backup rate. And I've had several patients who I've tried them on acetazolamide with their CPAP. So with that, I would stop and be happy to answer any questions if there's time.
So thank you, Dr. Badr. That was a really excellent talk. And even in the chat, people are commenting how wonderful it was. Every time that I listen to you giving a similar talk, I'm learning something new. So it's great. And you explained central sleep apnea, which is a very difficult topic in a very nice way. There are some comments coming up. So one of them, of course, was, will the slides be available? And I think I'll leave that to American Thoracic Society to tell everyone how they might be available. There is a question, any group of patients where you would try supplemental oxygen as first-line modality as opposed to CPAP?
No, because I'm always concerned about comorbid obstruction. There are very few patients we see where there's absolutely no evidence of comorbid obstructive events. Plus, even for pure central apnea, I think it will work. Plus, from a payer standpoint, it's much harder to get oxygen approved than to get CPAP approved.
Yeah, so until we have the results of that LOFT HF study, I think.
Exactly.
We won't
Exactly.
know. Yeah. Another question is, when using acetazolamide for CPAP treatment, what modalities do you use for follow-up sleeps? PSG, after what time period? Acetazolamide for CSA. If you use that, you follow them up.
So the ones I've used acetazolamide again with CPAP, not in lieu of. And what I've done, depending on whether I trust the download, I either use most of the time I try to use the download.
Download from the machine itself to see.
Download, yeah. That's what I've tried to use. In the old days before I trusted the download, I had to repeat studies, but I'm becoming very conscious of trying not to repeat studies unless they're really needed. So I prefer the download.
Okay, another question. It looked like patients with higher baseline PCO2 actually had less ventilatory reserve when it is lowered. Is that the case?
That is exactly the case, that's why I always emphasize this point, because the way all textbooks will talk about, they will talk about the apneic threshold as the actual trait. So if you have a low CO2, they say you're quote unquote closer to your apneic threshold. And that's actually what now we know is false. If you have a higher CO2, it is easier to lower your CO2 if you're starting from a higher CO2. And that's why I'm using the temperature analogy. If somebody has a hard time remembering it, just think it's easier to lower a temperature from a hot room than from a less hot room, from a euthermic room.
Yeah. And another question, any role of APAP for CSA?
No. That's it. I'm very worried because I think the algorithm will get very confused.
Okay. I don't see any more questions in the chat. Does anyone want to raise a hand and ask a question, or if there are any further questions in the chat? As mentioned in the chat area, that there's a link to this recording of this session, and it'll be provided for you as well if you want to go back and review. I think there's, what about AVAPs instead of ASV?
Some people are trying it. I don't have any problem trying it, but the experience, there's less published work on it. In principle, all of these are modalities that I'm prepared to try on a given patient.
And maybe for our some of our audience, or maybe our first-year fellows who may not be familiar with these modes of ventilation, could you just briefly tell us the difference between APAP and AVAPs in terms of what the acronym stands for?
Well, the APAP will assure you a volume. It's a volume assured. So it prevents you from decreasing that completely, while the other one is completely pressure driven. But most of the work is with ASV. So that's why I'm a little more cautious with AVAP.
Okay. And what's your approach to patients who cannot tolerate CPAP?
Oh, that's a tough one. People who cannot tolerate CPAP, then if they have obstructive apnea, we have to treat their obstructive apnea some other way. And if all they have is central apnea, then I'm prepared to treat them with something like acetazolamide. I've had a few of these, and they are actually a challenge any way you look at it. And one of my patients ended up not being on any treatment, even though he has unequivocal central apnea. So this is really a problem. If there is no evidence of any obstructive events, anything can be tried. They may be a perfect candidate for the phrenic nerve stimulation, for the neurostimulation, because they're unable to use CPAP. So that becomes really the only valid option for them. So
but that hasn't been formally studied for central sleep apnea. I mean, it's always in the context of obstructive sleep apnea, correct?
No, but the neurostimulation is just for central. So if they have only central apnea, we're not talking about the hypoglossal.
Yes, I just want to clarify that.
No, I'm talking about the phrenic.
Yes, the phrenic neurostimulation.
Yes, the phrenic. You're right. Thank you for alerting me, because there are two neurostimulations.
Yes.
So we need to be very careful. The hypoglossal is for the obstructive apnea. the phrenic is for the central apnea. So these are the patients who will be candidates for the phrenic neurostimulation, unilateral phrenic nerve stimulation. Again, my own preference is in cases like these is to try to do the simpler things, try to give them acetazolamide, try them on oxygen if I can do it, and be prepared for phrenic nerve stimulation. But it's not I had only one patient over the past 5 or 6 years whom I couldn't do anything with CPAP with them. These are the patients who need a lot more attention.
Yeah, I guess one of the questions I have with respect to the diagnostic approach is once you have diagnosed central sleep apnea on a polysomnography, do you as a pulmonologist pursue it further in order to try and find out why they have central sleep apnea? So would you do, if it's not obvious from history, would you be doing an MRI or doing an extensive medication history or something else to sort of figure out, is there another reason for that?
I do, but I'm not sure everybody, I don't know if that actually is value added in everyone, but at least I've tried to get a detailed medication history. I get an echo almost all the time in a case like this to make sure that at least we don't have a cardiac explanation for it. And there are times when I really don't have an answer. Now, I have to admit, is in the back of my mind, I'm always concerned about an undeclared use of opioid analgesics. And I don't have an answer to that one. So I go back and repeat the medication history multiple times to make sure that's not a possibility. But at the end of the day, once you rule out, I don't do MRI because I don't know what I'm looking for. Right. Although I do believe at some point, if we know what we're looking for, then there may be value, but at this point I don't. The most important thing, I want to make sure they don't have heart failure with reduced ejection fraction.
Yeah.
And once I establish that, then all the treatment approaches are the same.
Okay, so a couple more questions. For one person saying that for pediatric patients who can't tolerate the mask for any reason, such as Down syndrome children, PD-Palm at MGH is using gabapentin at bedtime. Do you have any experience for adults? And if
I've not used it in adults, and actually don't know much about treatment of children. I know it's very hard to induce a central apnea unless it's a CNS phenomenon in children. So the hypocapnic central apnea has never been shown in children. And that's why a lot of them, the mechanisms may be different. I'm very hesitant to use anything that suppresses arousals.
Okay. Another question, from your experience, any significant clinical difference, I guess, in the treatment of central apnea between using a low driving pressure BPAP, like 10/6, versus CPAP of 8, like that kind of approach?
My preference will be to go with CPAP if I could. However, I realize that some patients, when they need a very high CPAP pressure, that small difference in BPAP may add comfort, and I'm willing to consider it. But my preference is to go with CPAP in these patients, just because I don't want to create any reason for hyperventilation. Okay. But again, this is a bias. I'm not supported by data in what I'm saying.
And what is your approach with patients with combined CSA and COPD? So they have baseline hypercapnia, COPD with baseline hypercapnia.
I'm actually don't know how common this is. This is because I've always been searching for it in actually significantly bad COPD and central apnea. Because I'm not sure that with the high resistance that you can lower their CO2 that much. That's at least my thinking. The ones I've used them, I treat every condition. I probably have a handful of those. I treat every condition separately. I don't think they interfere with each other. Now, OHS is a completely different picture when you get into the very high CO2. But those, I have not seen that to be a big problem. I treat them separately.
Oh, and the comment about gabapentin actually was that they don't use it necessarily. They don't use it for the treatment of central sleep apnea. What they're using it is that it actually allows them to keep the mask on and therefore tolerate the CPAP better. So.
Oh, I see. Okay. Well, this has been tried, and gabapentin. Yeah, there are multiple medications that are used in adults to keep the mask on. I'm actually these things. I'm just don't like anything that affects arousal.
Yeah, absolutely. So would you agree that we are really at equipoise in the sense that although you know that CPAP is working for some of your patients, it is not, do you think it is the standard treatment in that sense, or do we really not know? And therefore, if we were to do research, it would be acceptable to stop someone's CPAP if they have central sleep apnea and not obstructive sleep apnea, and perhaps try another modality like, in this case, for example, the oxygen study we were talking about, or some other modality if it comes up.
Well, that's a beautiful question, Shireen. I did not tell you to ask me this question because I love to answer it. Actually, there is equipoise. I think there is significant equipoise. We've been carrying treatment approaches from a different condition, and we've been debating intermediate outcomes for the past 20 years. There is actually a question. We do not know the answer. So I would think that withholding CPAP in the setting of a clinical trial and testing something else is perfectly appropriate. Was that your question?
That was my question, yes.
Yes, I would think it's perfectly appropriate. And because we actually do not know. And this is how science stops moving, when people assume that some dogma is so powerful that you cannot challenge it.
Absolutely. Okay, well, thank you so much. We're right on time, 4 p.m. That was excellent. Thank you for sharing your experience with us. Every time, as I said, you give this talk and I'm learning something new, and I'm sure our fellows enjoyed it as well. And hopefully we can invite you back to the next Fellows Track Symposium in person, where we can have you ask these questions and other questions to our fellows and have them also be interactive. And
that would be wonderful. Looking forward to seeing everyone at the ATS next year in person.
Great. Thank you so much, Dr. Badr.
Thank you. Thanks a lot. Bye.